All right, so I think we should get started for the second part of our symposium, and it's my great pleasure to introduce Dr. Emanuela Guenova. So Dr. Guenova is Professor of Dermatology and a newly installed Chair of the Clinical Department of Immunodermatology at the Johannes Kepler University in Linz in Austria. So Dr. Guenova, she has published pivotal studies both in the field of cutaneous lymphomas, but also chronic inflammatory skin diseases, including atopic dermatitis and psoriasis. So she has a deep mechanistic, but also a very profound clinical and also histopathological understanding of both conditions, because she's also reading histopathology slides. So she really is one of the few people that really cover the triangle of histopathology, clinics, and molecular investigations. And we're very excited that you talk about this controversial topic, that is lymphomas and eczema therapeutics, conventional systemics, and JAK inhibitors.
Thank you very much, Patrick, and dear colleagues, for inviting me and having me here speak in this late Saturday afternoon on a controversial topic. But it's a hot topic, I realize, otherwise we wouldn't be here in this room in Paris at that time. And it's a topic that indeed puzzles me since more than 10 years. And 10 years ago, it wasn't so modern. You see, in not very popular journal already in 2016, we've been debating and looking for the common or different pathways, targetable pathways to address therapeutically atopic dermatitis and cutaneous lymphoma. And there are some convergences. Both of them somehow are type 2 diseases. That's why the hope to target them with the same drugs as we target atopic dermatitis. They have pruritus as a common denominator. A lot of shared immune pathways, and of course the topic of my talk today, this JAK-STAT dysregulation that is very prominent and well known also since many years, even before the era of the JAK inhibitors in cutaneous lymphoma. The problem with the JAK, or the fact or the good thing about the JAKs, is that they are multiple. There are 4 different JAK receptors paired with 7 STAT receptors, so you can imagine the number of combinations. And they all affect multiple cytokine pathways. I like to look at things in a more simplified manner. If we just have a look at the different JAKs 1 to 3 and TYK2, then you see that there are different cytokines, either the interferon or the IL-6 or more the IL-12, IL-23 signaling, or the common gamma chain that is affected, or specifically the JAK2, very important for hematopoiesis. That's how we had 20 years ago, actually, the first approval of ruxolitinib for myelofibrosis, systemic hematological disease. So the JAKs are somehow in between inflammation and hematological malignancies. If we look at them in comparison with biologic treatments for atopic dermatitis, we see that we go from a selective targeting with the biologics, the classical anti-cytokines, to a more broader targeting. And then here, again, depending on the type of JAK molecule that we're choosing, it can block part of the pathways with a more selective mechanism, or it can be a pan-JAK inhibitor, which has a broader immune suppression and less targeted effects. For atopic dermatitis, JAK inhibitors seem to be a very successful development. We profit from a rapid onset of treatment effectiveness and oral convenience. With the development of all those molecules, all of a sudden it became very relevant, as we are discussing the whole afternoon today, the fact that cutaneous lymphoma mimic quite to some extent clinically, but also histologically, and also in some molecular features, benign inflammation, specifically eczema. Before the era of the modern treatments, it wasn't so relevant because most of the treatment options were identical, like topical steroids, phototherapy, retinoids, or methotrexate. So maybe many cases of lymphoma actually never unmasked or were never spotted as such. But now, by probably unmasking over targeted therapies, first we increase, of course, the incidence of cutaneous lymphoma, and then we run into this debate. Can we treat with the same drugs? Are they worsening? Are they improving, specifically for the JAKs? A very controversial tema yet. But the same is true also for the other biologics. Just a short recapitulation, the highest evidence or the most robust signal from published literature we have for dupilumab, more than 150 cases that report that even though there may be an initial improvement of disease, like the AD-like symptoms, at the end over this therapy, patients with CTCL tend to develop tumor lesions, more erythroderma and nodules. And currently we frame it like unmasking of the disease and not so much necessarily direct induction. For JAK inhibitors, they are rare, some reports, but still quite a few communications. But it has been reported that CTCL, Sézary syndrome, or mycosis fungoides can emerge during this therapy. Same is true also for biologic for psoriasis. What's interesting in the registries, official registries, and data from clinical trials, no consistent increase in CTCL under those therapies has yet been documented. What kind of evidence do you have for JAK inhibitors, first in overall in all T-cell lymphoma entities, including peripheral T-cell lymphoma and rare entities like NK T-cell lymphoma? So most of those are systemic lymphomas, not necessarily cutaneous. So if you look at the currently available data on clinicaltrials.gov, you will see that in ruxolitinib, there are two running trials. One is in combination with duvelisib, and there is the Jackpot 8 clinical trial of golidocitinib, and then we have here cerudulatinib, dual SIK-JAK inhibitor, and then TOFA, a topical treatment of axitinib, and one pacritinib trial in overall T-cell lymphoproliferative neoplasms. So most of the clinical trials are not specifically designed for cutaneous lymphoma exclusively. They encompass all T-cell malignancies, predominantly systemic ones, and most of those are ongoing. So we have data from the golidocitinib trial and from the cerudulatinib trial, and I will show you those specifically. One of the first reported and finalized trial on T-cell lymphoma was with ruxolitinib. This is a closed study, so it was not on the previous list. And this study encompassed also peripheral T-cell lymphoma and MF and SS, and it was stratified into patients that have an activating STAT3 or JAK mutation that do not have a relevance evidence for such a mutation, or it was unknown, and they received ruxolitinib. And then you see that most of the patients were with peripheral T-cell lymphoma, and a very few with mycosis fungoides in all the three arms. And the results from this study, and I would tend to say that here we can extrapolate the data predominantly for non-MF variants, because the majority of the patients were with peripheral T-cell lymphoma. We have 50% response if the patients were from the group of activating JAK-STAT mutation, and way lower responses in the absence of mutation or the absence of information. One potential molecular criteria to judge for response could be the phospho-S6 expression. This is a phosphorylated protein that is in the PA3K kinase activation pathway. These data have been published 4 or 5 years ago And so far, that's the most robust evidence that we have on ruxolitinib systemic in MF. The golidocitinib, this is a very selective JAK1 inhibitor. You see also recently published and accomplished clinical trial in peripheral T-cell lymphoma. If you look precisely at the histological subtype of the treated entities, you will see that hardly any cutaneous T-cell lymphoma has been included. There are multiple NOS T-cell lymphoma, multiple angioimmunoblastic T-cell lymphoma, some NK T-cell lymphoma, some ALK-positive systemic lymphoma, but no MF or SS in this cohort. Nevertheless, those are T-cell lymphoma entities, and they have been exposed to JAK1 inhibitor. And the overall response rate is probably one of the best for the whole evidence of JAK in T-cell malignancies. Objective response rate of 39% approximately, and you see here also very persuasive and promising approach from the waterfall plot. Now, clinical evidence in CTCL specifically. What I could found after carefully checking registered, published trial and also abstracts, because most of those data are not yet available in the form of publication, but in a different type of communication, is the Moshkovich trial, still partially ongoing, with ruxolitinib, with MFSS reported rate 15 to 25%. Then the preliminary data of the zerdulatinib trial, 35%, and this is the best response rate that we have so far in the context of advanced CTCL and JAK inhibition. Then for tofacitinib, first there is the ongoing trial of topical application where there have been no results communicated. There are variable case reports with variable outcomes, so I found the level of evidence here quite low. And then there is the Patrick Brunner's clinical trial that has been initiated in New York, and I was very surprised while preparing this talk to see that there is no significant improvement. Is that true, Patrick? I just got it from the literature and I was upset because I was actually betting on that one, that we will get some positive direction, but obviously not, and the leader of the trial confirms. So internet is correct. So for me, as a personal message out of this extensive literature search of all ongoing and communicated clinical data, and based also on our molecular knowledge, there may be a chance for JAK inhibitors in some subtypes of cutaneous or non-cutaneous T-cell lymphoma. Most probably the response rate will correlate with the specific JAK-STAT pathway that we target, and also with the specific mutations that the patients have. They can be, in the case of cutaneous lymphoma, both activating and suppressing. So we have the gas and break problematic of enhancing malignancy or improving malignancy over the same pathway. What are the treatment limitations? We have a myriad of different JAK and STAT mutations in cutaneous lymphoma. There is a molecular heterogeneity because of this. Of course, there may be resistance development to any kind of targeted treatment, but also there is a progression risk, especially if we can accelerate the development of the tumor by hitting a JAK target that is actually proactive for the development of the tumor. It has been communicated that JAK-STAT dysregulation in cutaneous lymphoma biology affects both oncogenic and anti-oncogenic protective signaling. So STAT3 and STAT5B have been since very long time known to promote cellular transformation and survival. And JAK2 axis, STAT4, has been associated with tumor suppressive signals. STAT3 inhibition, especially from the Leiden group, has been interrogated since many, many years as one potential trial. So I think we need some fine-tuning here until we find the pro or contra. Today I cannot give you a real answer if JAK are promising for the treatment of cutaneous lymphoma. Looking at the pipeline, there are a few new molecules, at least, to come, and I'm sure many more. Actually, the field is very broad. If you also look at what is being developed for hematological malignancies, the future of the JAK inhibitors probably will go in combination targeting, so dual inhibition to enhance efficacy, and different targets also to increase targeted effect or include different pathways that have not been targeted yet, and then over T-cell specific targeting, we might hope that there will be a more precise approach to target CTCL. So now if we compare with atopic dermatitis, if we put this into a historical perspective, in the 80s, 90s, we had cyclosporine, methotrexate, and actually retinoids to some extent for established systemic treatments for atopic dermatitis. And at least one of those remained successful for the treatment of CTCL as well. Then in the 2010 rough estimation, we had the hype of biologic therapies, very, very successful for treating inflammatory skin diseases, but nowadays with the problematic for unmasking cutaneous lymphoma, both coming from psoriasis or atopic dermatitis field. Those are mostly the anti-cytokine therapies. And now we are coming to the JAK inhibitor era, where still don't know exactly what's happening. If we have a chance to improve CTCL, certainly most probably not exactly with the same JAK molecules that we're using from atopic dermatitis, probably more specific JAKs that come from the hematology field and target different parts of the complicated JAK-STAT signaling pathway. If we look at the guidelines for atopic dermatitis that just appeared in the Journal of the European Academy of Dermatology and Venereology a few days ago, we will see that in the complicated scheme with multiple different treatments, what I have marked in red is what holds true for CTCL as well. And these are the old, well-known topical corticosteroids, then the narrowband UVB, as a treatment for cutaneous lymphoma as well, and then methotrexate. Everything else that is approved or recommended for treating atopic dermatitis is actually not recommended for treating cutaneous lymphoma. And here it's very important to start thinking differently and diagnosing properly those two diseases. Just to make it complete, what are the guidelines for treating cutaneous lymphoma? Early stage disease, so those are also the greatest mimicker of eczema, specifically those 1A, 1B disease. You see that UVB and PUVA and topical corticosteroids are identical as treating atopic dermatitis, and the rest, topical chlormethin, localized radiotherapy, is actually not. And the level of evidence for those is good, level of evidence 2. That means there are some prospective data for phototherapy, but not necessarily for corticosteroids. And now, of course, you want to know what's the situation for methotrexate. Methotrexate is the only overlapping systemic drug for both AD and MF recommended in guidelines. And it is recommended as a first-line treatment option for advanced disease, as a second-line treatment option for early-stage disease, so the mimickers of AD. And you see that the level of evidence is actually very, very low. It is 4. That means there has never been a prospectively obtained large collection of data to prove the effect. So cross-disease efficacy of all classical drugs and JAK inhibitors can be, at the moment, postulated for methotrexate only, according to clinical experience and recommendations and published guidelines. In both diseases, it comes with a modest efficacy, And for atopic dermatitis, data are for EASI 50 around 40–50%, and overall response rate for cutaneous lymphoma, level of evidence 4 of those data, is up to 50%, 55% in early stage disease. Maybe they have a kind of a common mechanism of action, inhibiting T-cell proliferation. In both diseases, they can be used in a combination treatment approach, also with phototherapy. And in both diseases, they might be suitable for maintenance therapy, at least according to recommendations. I'm sure in both diseases, it's quite rarely used in this setting now in the era of new therapies. Cyclosporin belongs also to the topic classical therapies. Cyclosporin was widely used in atopic dermatitis. Now, of course, with the development of all those new successful treatments, the use is drastically declining. It has a good efficacy and very rapid effect. We still need it definitely for some refractory AD patients. There are challenges with the tolerability, and for AD, it's definitely a strategic use to bridge, receive remission or improvement of the disease, and then change to a more long-term treatment strategy with biologics or JAK inhibitors. The discussion about cyclosporin in CTCL is very clear. It's actually contraindicated because it worsens disease. The discussion that we're having now with biologics or JAK inhibitors may have a different outcome in the future, but the same discussion we had 20 years ago about cyclosporin. And meanwhile, this is a very clear positioning here. Cyclosporin is worsening CTCL and is actually contraindicated as soon as you know that you have a CTCL in front of you. It has been used in many cases that have been underdiagnosed or diagnosed as eczema, and that's how we have accumulated this knowledge so far. If we compare the two treatment algorithms in atopic dermatitis and cutaneous lymphoma, what's similar that in mild disease, of course, we have topical therapies and skin-directed therapies, and phototherapy is an option for both, especially UVB phototherapy. The skin-directed therapies are, with the exception of corticosteroids, actually different. For skin lymphoma, we use topical chemotherapy, we use radiotherapy. Those are strategies that are definitely not an option for atopic dermatitis. And the big difference is in moderate and severe and advanced disease, as we call this in the CTCL management. In both, we favor new therapies with higher level of evidence compared to old conventional systemic therapies. Atopic dermatitis, biologic JAK inhibitors make really a revolution. In cutaneous lymphoma, it's a completely different landscape with targeted antibodies or combination therapies or immunotherapy. The new knowledge here is that we definitely favor immunotherapy to chemotherapy in cutaneous lymphoma. And then when things become refractory and very advanced, maybe due to the lack of knowledge, there is a similarity, again, of course, clinical trials and experimental approaches. And what is an option and should never be forgotten for cutaneous lymphoma, the only curative option at the moment is the allogeneic stem cell transplantation that should be considered early in the treatment of the disease. So with that, I admit that the topic remains controversial, but at least I really made an effort. I searched the literature for you. And if somebody has access to different data or different knowledge, I'm happy to share it with me. For me, the questions remains open with a slight tendency to say that I remain a little bit skeptical about the role of JAK inhibitors developed for atopic dermatitis in the treatment of CTCL. Thank you.
Thank you so much for this wonderful and comprehensive talk. We're going to take questions in the end, if that's all right. And I'm very excited to ask Dr. Shamir Geller on stage. So he's attending physician at Sloan Kettering and associate professor at the Department of Dermatology at Weill Cornell Medicine. And he will tell us about the biologic side of the story.
So thank you very much for having me and giving me to deliver this very interesting and I think very under the spotlight topic. So I will focus on biologics for atopic dermatitis and their possible association with lymphomas, skin lymphomas. I will talk only about the IL-13, IL-4 blockers. As for IL-31, we do not actually have any information. My personal experience, I haven't seen any patient who developed CTCL under NEMO, and there are some thoughts about using NEMO also for managing itch in CTCL patients, but we need more literature on that, so I won't discuss that. So as it was nicely presented in the earlier session and also by some of my colleagues in this session, so there are a lot of similarities between these two conditions, although one is much more prevalent, atopic dermatitis, and the other is quite rare. Still, when dupilumab was introduced into the treatment toolbox that we have for atopic dermatitis back in 2017, we were, as in the CTCL community, we were very excited because both the clinical similarities and the overlap in the pathways, the Th2 as was well described before by Dr. Brunner, made us think that here we're gonna have something that is gonna serve us as clinicians who treat patients with CTCL. And we were very excited to see how this can be helpful for our patients. And this was also based on previous data that we had about the role of interleukin-13 in cutaneous T-cell lymphoma. This is a study that was published in Blood by Larissa Gaskin and her team, showing that interleukin-13 and its receptors, both interleukin-13 alpha-1 and alpha-2, are highly expressed in clinically CTCL involved skin. In biopsies, blood and skin lymphoma cell produce these interleukin and express both receptors, and it induces cell growth in vitro, signaling through the interleukin-13 alpha-1 receptor. Interleukin-13 immunopositivity was correlated with disease progression, as you can see here. The higher the stage, you see more expression of both the interleukin and its receptors. And antibody-mediated neutralization of interleukin-13 or soluble interleukin-13 alpha-1, the dupilumab, can lead to inhibition of tumor cell proliferation. So this study actually made us think, okay, we have a green light here to use this in CTCL patients and probably to see some improvement. This was further enhanced also by the activity of dupilumab against itch that is associated with cancer or with medications. We know that blocking interleukin-4 and interleukin-13 activity reduces the synthesis of interleukin-31 and its receptors, which are also present on the itch nerves, and blocking these receptors can alleviate cancer and medication-related pruritus, making this a possible treatment option for our Sézary patients, as was described before. So there was a lot of buildup about dupilumab entering our treatment world. And indeed, the first case report that we have about CTCL patients and the use of dupilumab actually was in patients who had both diseases, both atopic dermatitis. This is a publication of a case from UPenn showing that a patient responded both regarding his atopic dermatitis and his CTCL while he was on dupilumab. Another case that was presented from Switzerland, from the group in Bern, actually showed rapid and sustained control of the itch and reduction in the Th2 activity in a patient who was already on ECP, extracorporeal photopheresis, who got, in addition to that, dupilumab, and the patient, as you can see here, responded very well, and specifically the itch was gone almost completely. What was interesting in this study is that it was also taken into the into the bench aspect, and the patient's blood was assessed, showing that when you study the Sézary cells, adding interleukin-4 and interleukin-13 actually causes a decrease in apoptosis, and the increase in the inflammation. And then when you block that with dupilumab, actually you manage to enhance the anti-apoptotic and to antagonize the anti-apoptotic and the proliferation and activation, also showing the rationale in using dupilumab for these patients. So again, green light was given from these initial studies on specific patients. But then we got this report, which is the first report about CTCL following dupilumab exposure, again in a small journal, not one of the largest one, but showing the first report in the literature. So it was back in 2019, about the same time that we had the positive results. So it was a mixed reports from the beginning. And this is a patient with a history of childhood atopic dermatitis that resolved in adolescent. Eczema reappeared at the age of 47, which is already a red flag. Dupilumab was started for atopic dermatitis that was diagnosed clinically only. The patient never had a biopsy before. No improvement was seen on dupilumab. He clinically exacerbated after a month what led to doing a biopsy, and that actually showed MF with monoclonality. And dupilumab was stopped. The patient was switched to Nerab and UVB, and at least based on the report, he responded well. So this was the first red flag about this possible association. What's interesting is that already in this first report, the authors finalized their case report with a very important message, saying that the differential diagnosis between severe AD and early MF is often difficult, and it should be borne in mind that adult onset atopic dermatitis is often found to be MF or Sézary. And that is really important because all of this association is seen in adult patients. We do not see this association, and I will get to that, in a pediatric population. Following this case, we had this report which made much more waves and much more noise. This is a case series that was published in the JAD in 2020, and this actually looked into patients who either received dupilumab for atopic dermatitis or their physicians tried to see how it will work on their CTCL. And what was very alarming here was that 4 of these patients actually progressed, and 3 out of these 4 died due to their CTCL, which made many physicians and clinicians hold off with giving dupilumab to patients with CTCL, and actually started raising this whole issue of whether dupilumab can actually cause lymphoma, which is something that we don't have evidence for. And nowadays, when we already have a lot of data, it's probably not doing that. It's more affecting or doing what we consider as exposure in underlying disease or unmasking it. But at this point, it was really unclear with these 3 cases what was going on. And then many patients with even suspected CTCL were really avoided or prevented from getting dupilumab, which is the other side of the pendulum, being too cautious, and patients who might benefit from dupilumab are prevented from getting this treatment that can actually help them just because a biopsy showed some atypical lymphocytic infiltrate, or I had a patient who said that his biopsy had T-cell dyscrasia in a biopsy. And although he has a clinically apparent atopic dermatitis, nobody's giving him this drug. So I started giving him this drug, following for him for not, developing CTCL, but eventually most of the patients with atopic dermatitis are going to benefit from this drug. So this is actually the paper that took the pendulum to the redder side of the spectrum. This you already saw, this study. So at 2023, actually all of these cases reported were pulled together, put into a systematic review, showing that we are talking about, at the time it was 23 reported cases. Again, you can see that the age ranges. No one is less than 27. We don't have pediatric cases. 19 of the patients had adult onset atopic dermatitis. Only 4 had history of a diagnosis in childhood. 20 of the patients were diagnosed with MF after their exposure to dupilumab. 3 with Sézary syndrome, 11 with advanced disease. Mean time was about 7.5 months from starting dupilumab and until they had a biopsy proving MF. It was mentioned before, we do see many times that these patients first respond well to the treatment, and then there is some progression or recurrence of their disease. What's interesting and what's the million-dollar question, was the CTCL there before? Is it a misdiagnosis? Was there maybe a subclinical clone underlying? So pre-dupilumab biopsies performed in 13 of the cases, 57%, and were not diagnostic of MF, Sézary syndrome. 5 patients did have atypical features of atopic dermatitis on the biopsy, epidermotropism, follicular tropism, some lichenoid inflammation. None of the reported tissue cell clonality assessed, none of the cases had actually been worked up for T-cell clonality in these cases. So this is what we had back then, which is only 2 years ago, only this small case series. So what's going on the larger picture, larger more strategic registries, population-based studies? So TriNetX is a collaborative clinical research platform that actually gathers medical records from 60 healthcare organizations in the US, pulling all of that data de-identified together. And what was performed in this study, also well known to those of you who follow this, by Hassan in the JAD in 2024, a paper that actually made a lot of waves afterward with all of the letters to the, including you, I think, Patrick, you sent them a letter to the editor following this paper because there was a lot of questions about the methodology of this. And dealing with these big, large registries, it's hard because the diagnosis is not very well described. Many of these patients, we're not sure what biopsies showed, how severe was their atopic dermatitis, so it's quite hard. But the idea was that they looked into this, medical records of patients with CTCL and lymphoma that developed CTCL or lymphoma in a group of atopic dermatitis patients who used dupilumab, and they had almost 23,000 of those, and compare these ratios to the patients who never used dupilumab, which was over 1 million patients. The first thing that is important to understand, we are talking about a very rare incidence of CTCL among patients who get dupilumab. Here it's less than 0.2% of the patients. 41 cases, that's all they had out of these over 1 million of patients who had atopic dermatitis. And within the patients who got dupilumab, it's 23,000. And you can see that the increased risk of CTCL with dupilumab the odds ratio was 4.1. It was not seen with other cutaneous or lymphoid malignancies. And most of the cases were, again, we are talking about a time frame of 1 year of dupilumab use. We did a similar study using a different registry, the FAREST, the FDA reporting system, which also has a lot of pitfalls about selection bias and reporting bias. And some of that, actually, a lot of these reports are because of these case reports I've shown you that were presented, and people started paying more attention to that. But we looked into the time period of 2017 to 2023. There were over 167,000 reports on adverse effects for patients who got dupilumab for any indication. Cutaneous lymphoma was reported in only 113 cases. So out of the adverse effects that were reported, we're sure there are many of the adverse effects that were not reported, only less than 0.1% were actually cutaneous lymphoma that were suspected to be associated with the dupilumab use. Under dupilumab, there was increase in the reported of cutaneous T-cell lymphoma when you compare it to other medications like interleukin-23, interleukin-17, TNFs, etc. Dupilumab has the highest reporting overall ratios, and the signal for CTCL was stronger for dupilumab compared to not only to the other treatments, but we also looked at the same thing on lymphoma, and we didn't see any increase on lymphoma. So we're talking about a specific signal that is only on skin lymphoma. All of the cases had indications for dupilumab. The indication for dupilumab was atopic dermatitis or skin condition. And we have to understand that we're talking about this study. Back in 2018, dupilumab was approved for asthma. I've never seen a patient who developed CTCL after getting dupilumab for his asthma, or for EOE, or for polyposis, or for any other non-skin indications. And there is none in the literature, and also in the forest, there is none. Meaning that I think that this is the strongest proof that dupilumab by itself is not an oncogenic drug. It cannot create out of nowhere lymphoma. There needs to be something, whether it's a topic that emerges into lymphoma, or underlying clone or underlying misdiagnosed lymphoma that is there in the skin, and then it's like unmasked or driven by dupilumab later on. So all of these studies that I showed you were either case reports or large registries, which are difficult to interpret regarding the proof in the biopsies. When we go to specific single centers, we can see here one single center study done in Seoul, Korea. They took all of their patients between 2018 and 2023 who were treated with dupilumab for atopic dermatitis. Out of them, they showed that 46 patients were not responding as expected to dupilumab, and eventually 19 of them had MF, giving us a number that is quite high, that 5% of the patients who were started with dupilumab at this center eventually had MF. Another study, similar study, did the same in Utrecht in the Netherlands. Over here, they took 530 patients atopic dermatitis with dupilumab. Their numbers were much lower, which more are more in line with the studies that I showed you with the larger cohort studies and the larger registries. 0.6%. They had only 3 patients that eventually developed MF with dupilumab. What they did report, and you did see this study because it was mentioned by Dr. Brunner and also by Pietro, they did find that there are patients who develop this lymphoid reaction, meaning something that we cannot call it CTCL, but it is some atypical lymphocytic infiltrate that looks clinically like, might look like lymphoma. And eventually on all of these 11 patients, the pre-dupilumab biopsy confirmed atopic dermatitis, and all of them, by the way, resolved after stopping dupilumab. So it is complicated. We did a similar single-center study on our experience with patients. We took all of the patients that we saw in the cutaneous lymphoma clinic who had history of dupilumab use, again, for any reason. We find 27 patients like that. All cases were prescribed for atopic dermatitis, like I said. 67% of the patients had diagnosis of atopic dermatitis based on a skin biopsy. We managed to get only 5 out of the 18 biopsies from before dupilumab to be reviewed at Memorial. 4 of them were truly atopic dermatitis also when we looked at that. 1 of them was mycosis fungoides. So it was, based on these very small numbers, we are talking about not the majority of the cases, it's truly misdiagnosis. So probably it's like more like a clonal dermatitis. We haven't discussed that option. Is that something we believe that exists or not? But there was maybe something going on there. We didn't assess clonality on these cases. Most of them, we just received the slides. Time from dupilumab treatment start to CTCL diagnosis was again something like almost a year, and most of them were early stage, unlike previous presentation, previous data. We didn't see like explosive disease following exposure to dupilumab. We looked into the outcomes of these patients by simply, for the 27 patients that we had, we matched each one of them with the next patient who was diagnosed at the same stage and followed at Memorial. And we showed that, looking into patients who are dupilumab associated with versus never had dupilumab, the overall survival were the same. Again, the follow-ups were not as long as we would like, but there was nothing that was like exacerbated or severely rapidly growing. And also progression-free survival was not different between the 2 groups. One of the pushbacks we got about our work in the different papers we published, that what we report is not actually a measure of, is not like an effect of dupilumab, but more of an effect of the chronic severe atopic dermatitis that eventually in some cases develops into cutaneous T-cell lymphoma. So we said, okay, let's look into patients who don't get dupilumab, but do get other treatments like JAK inhibitors. Are they having the same ratios of developing CTCL after exposure to these drugs? Apparently, it's the same patients who should get like either one, like we saw with Dr. Emanuela, how she presented the algorithm of treatment. And from our experience at Memorial, we do not have any patient who were solely exposed to JAK inhibitor. The only 2 patients we had during this time frame, and we looked into patients from 2011 when JAK inhibitors were approved, we had only 2 patients, and both of them were also exposed to dupilumab. So we don't have any patient with JAK inhibitor developing CTCL. Furthermore, we went to the FOREST database and we did another analysis and showed that we do not see a signal there as well. So JAK inhibitor doesn't have like increased reported risk for JAK inhibitors compared to the 8.8 risk that we see in dupilumab. And regarding other interleukin-13 blockers, Tralo, for example, and for that we do not see also any signal. What we see is 1 case report, and we do see a study on the FOREST that did report 4 cases, but there was no information about them. So it's very hard to tell. So far at MSK, we haven't had any patient with other, neither Nemo or Tralo or anything else other than the what I presented to you. So our data challenged the concept that severe chronic atopic dermatitis is the cause of CTCL. We see it here, it's like in specific population, it's more adults. We see it in specific treatments with the dupilumab, and we see it with a disease specific, which is skin disorders that are the target of treating with the dupilumab. We do not see it with other indications. This was also, Pietro mentioned that, this is the possible mechanism, but again, it's an hypothesis. When you take this data about the interleukin-13 and how it, through the alpha-2 receptor, eventually causes a proliferation of T-cell lymphomas, it doesn't really goes along with the data I showed you at the beginning about these 2 cases that it was done in vitro studies. Over there we saw that actually dupilumab can help in reducing the proliferation and the effect of interleukin-13 on Sézary and MF cells. So it's really unclear. My thoughts are that the effect of unmasking is more through the tumor microenvironment, on the Th2 effect that disease has, and not on the specific, directly on the CTCL cells. This is a paper that we actually put together just because all of this confusion. I have like 3 minutes to go over that, right? Okay. Yeah. So this is like, because of all of this confusion, we put together based on our experience on the literature, like I just reviewed with you. So this is a paper just accepted to American Journal of Clinical Dermatology. It gives like clinicians recommendations of what to do in these patients. So I will go over that. I know you saw it briefly, but I think it's important to present that. So for atopic dermatitis, prior to initiating dupilumab, when disease history, clinical appearance, and histological features support the diagnosis of atopic dermatitis, you can give dupilumab or other options, but you shouldn't avoid the patients from getting dupilumab. In patients with adult onset atopic dermatitis or a typical clinical presentation like thick plaques, tumor, erythroderma, in pediatric patients with a typical clinical presentation, rule out possible CTCL. It's a skin biopsy, it can save the patient and everybody, all this limbo of going through, starting this treatment and things start to get worse. After initiating dupilumab, closely monitor patients with a typical presentation of atopic dermatitis. Rule out CTCL if patient's response to dupilumab is inadequate, if rash worsens, tumors, erythroderma, lymphadenopathy develop. repeat the biopsies. For cutaneous T-cell lymphomas, avoid dupilumab use in patients with confirmed or suspected CTCL. This is our approach at Memorial, although there are some reports about using dupilumab to treat drug rashes like mogamulizumab rash, which is something very common for the clinicians who treat patients with advanced stage. We do not use dupilumab. If we do need something to reduce Th2 activity, we prefer to use JAK inhibitors in these patients with suspected or confirmed CTCL. Again, following them very closely, like line 2 here says, consider alternative therapies for concurrent indications, whether it's atopic, asthma, or others in these patients. For other lymphomas, non-CTCL lymphomas, dupilumab can be used in patients with non-cutaneous lymphoma. We looked, the studies we did in our center, we didn't see any issues or any hematological malignancies that were not CTCL that actually developed with patients under dupilumab. We had one case of primary cutaneous follicle central lymphoma, but I think it's just a coincidence. Other than that, we had no other cases of other cutaneous or non-cutaneous lymphoma developing under dupilumab. And also the larger series, like I showed you, the forest, etc., they don't show any of this risk associated. Caution should be maintained, of course, for any new rash or skin lesions with low threshold for skin biopsy. I would like to thank you for your attendance now at this time. It's not taken for granted. And for the team who works with me at Memorial Sloan Kettering on this interesting topic. And you can reach out to me by email or by reaching out through LinkedIn. You have the connect here. Thank you very much.
Thanks so much for this fabulous talk. And as the grande finale, I'm asking Yael Hashem, my co-chair, to give us a pragmatic approach to complex cases.
Thanks, Patrick. Okay. So this talk is going to be a very, very clinical talk, and this is in part because it's late in the afternoon of the last day of the EADV. I think our capacity for data is kind of limited, and also because we really don't have a lot of data to guide us on how to make decisions in these complex cases. And at the end of the day, we really end up coming back to good old morphological diagnosis. So we'll do a case-based exploration of some complex cases and try to outline a pragmatic approach that will hopefully help us all tomorrow, the next day, when we go back to clinic and we see these patients. So first off, to put things in context, we've heard a lot about how difficult it is to differentiate eczema from mycosis fungoides, but it may be a bit reassuring to remember that it's often not that misleading. So if you have a classic case of these classic patches or thin plaques, bathing suit distribution, kidney shape, polymorphous, etc., usually minimal to no itch, then it's usually pretty straightforward diagnosis. And kind of on the other end of this spectrum, if we have these really advanced stages, and definitely if we have tumors, again, with careful assessment, we can usually manage. So I think the cases we really struggle with are kind of these cases. So you have a patient coming in with a really extensive, possibly eczematous eruption, super itchy, very symptomatic, and then things get hard. And in these situations, it's not just atopic dermatitis, which is in the differential, it's actually moderate to severe atopic dermatitis, right? And that brings in the whole issue of advanced therapeutics, which we just heard about today. And then if it's CTCL, again, from our real-life experience, these cases often turn out to have advanced stage CTCL. So kind of the last cases you want to delay your diagnosis in. I can tell you now that one of these patients has severe atopic dermatitis, the other has advanced stage CTCL. So take a look and see how comfortable you are committing to the diagnosis here. And later on, I'll show you which is which. And as we've heard again, it's easy to understand why these two differentials come together. They both have the Th2 phenotype with the peripheral eosinophilia, elevated IgE is very common, elevated LDH, and we have the barrier defects, so a lot of cirrhosis, and we also have cutaneous infections in both. So a lot of immunological similarities. And we tried to ask ourselves, as we were wading through this mire of differentiating the two, what do these patients look like the minute before they have these tumors, right? The minute before they accelerate. Are there any clues that we can find to capture these patients? So we tried to use hindsight, which is, as we all know, 2020, and this is a project led by my close friend, Iris Amitai from our lymphoma clinic. We looked at cases from our lymphoma clinic. So these are people with diagnosed MF or Sézary syndrome, and then looked for those cases that presented beforehand with those generalized pruritic rashes that got a diagnosis of moderate to severe atopic dermatitis by a dermatologist. And there weren't a lot of these patients, so this is good news in a way. We found 13 patients, mostly fair-skinned. So most of these patients had so-called late-onset atopic dermatitis, as Shamir showed us in all the other prior studies on CTCL after dupilumab. This is kind of a red flag, definitely something to be concerned about. But please note the complementary figure here, and that's basically that 3 patients had childhood atopic dermatitis, and about half of them had a personal family history of atopy. So just a very simple reminder that atopic dermatitis and atopy are just common in the general populations, and we should not necessarily be lulled into a sense of security that this is atopic dermatitis necessarily. And similarly, a lot of patients had eosinophilia, and about half had elevated IgE. And this is something I see often with residents. If somebody comes in, he has a generalized eczematous rash, and he has that IgE, I think young career dermatologists or young doctors, we love tests. So that's AD. So just a brief reminder, IgE has an extensive differential diagnosis as well. So all of them had an extensive pruritic rash. You may remember this patient from the prior slide. And I think we can, make sense to think this is some sort of a papillary dermatitis, whatever that is. She has some lichenification in the antecubital folds, really severely itchy. And unfortunately, when she went on to develop this clinical picture, that's when she got worked up, and that's when she was diagnosed with stage 4A2 mycosis fungoides with large cell transformation, unfortunately. About half of the patients had these classic, psoriasiform sebderm-like presentations, diffuse scalp sebderm-like, and then these psoriasiform or figurate well-demarcated plaques, which you can sometimes see. About a quarter had what Emmy talked about in the childhood population. So this is an adult population, follicular accentuation or KP-like lesions, but again, very atypical ones, very confluent, areas you wouldn't expect to see it, or in a background of kind of large erythematous plaques. And then this, for me, was actually a very disconcerting finding. About half of patients presented with some sort of dyshidrotic eczema or vesicular eczema, either involving the palms or the soles or both. And I have to say, when I see this, I'm usually kind of encouraged that I'm talking about eczema, but this can be a really strong presentation for CTCL. A subtle clue here is that some of these patients develop infections in the palms and soles. Now, obviously, eczema, we all know, goes very strongly along with staph infections or cutaneous infections, but not usually in these locations. And these patients often go on to develop hyperkeratosis, usually not confluent, and this is a very strong red flag. Emmy taught me this, a very strong red flag for CTCL when you see that. And this patient went on to be diagnosed with stage 4A1 mycosis fungoides. This is another presentation you can see in the hands, kind of pruritic lichenified so-called hand eczema, but I don't know if you can see that subtle clinical sign here. Take a look if something pops up. So look at the fingernails. Kind of odd to see 10-nail involvement with green nail, right? Pseudomonas infection. Again, possibly a subtle clue thinking about the cutaneous infections you see in mycosis fungoides. So 10 of these patients did undergo biopsies. So most of these patients were referred to us later on, but we went back and we actually got all these biopsies and we looked at them, similar to what Shamir did at MSK, and we went over them with our dermatopathologists, and they all showed spongiotic dermatitis. About half of them psoriasiform spongiotic dermatitis. I don't want you to take home, a message here is not don't biopsy, it's not gonna help you. The message here is definitely re-biopsy. Okay, just be very cautious in re-biopsy and be aware that dermatitis at one point does not necessarily negate CTCL later on. Patients got all kinds of treatments. 4 of them got advanced therapeutics, 3 dupilumab and 1 upadacitinib. And then this was their final staging. So except for 1 patient who had early PAT stage disease, all of the others had advanced stage mycosis fungoides. Unfortunately, despite intense treatment, 4 of them have since been deceased. But I do want to point out that only 4 of these patients got advanced therapeutics. So just a reminder that that's kind of the natural history sometimes of advanced stage disease as well. So these were cases that we knew about. We kind of knew the end diagnosis. All of these clinical signs can go both ways. There's nothing that's specific for either diagnosis, but let's see if we can apply these lessons when a patient walks in and we don't know what he has. So this is a patient who had an extensive pruritic rash since he was 36. He was diagnosed at another very, very good center in Israel with adult onset AD at age 38. Had no atopic history, had normal IgE. He had 3 biopsies done. And I think when you have 3 biopsies done, you kind of know something was a bit weird, right, in this presentation. All showing spongiotic psoriasiform dermatitis. And he cycled through, the regular treatments, and his symptom burden grew and grew, and he was finally referred to our clinic. So these are pictures of, you can't really say, right? Eczema doesn't photograph that well, so some sort of diffuse, possibly eczematous rash. You can see some probable staph going on there in the shoulders. But then you start to kind of look more deep, in depth. So he had this seborrheic dermatitis-like involvement of the face and the scalp. Sometimes you can see something similar to that after Dupy, so the Dupy red face, kind of that sticks around, but again, a bit weird. And then this psoriasiform hypopigmented plaques. This is a skin type 2 patient, and this presentation, again, a little bit odd. And then if you look at the margins of that general eczematous rash, you can see it's actually it's really well demarcated. You don't get these blurry eczema borders. He also had dyshidrotic hand eczema, which I'm no longer reassured by, and he also had a bit of plantar hyperkeratosis. So we reassessed him, and this patient turned out to have mycosis fungoides stage 4A1. This is what he looks like today. A very unfortunate case. And you can see in the left picture, you can see in the sole kind of that dyshidrotic eczema remnant, sort of. And this is just to remind us of what the patients look when they come in and what they look like later. So for my final case, this is a 46-year-old man, and he's had atopic dermatitis since he was 20 years old. And I'd love for someone to tell me if that is adult onset or child onset atopic dermatitis. I guess it's adults, but it's kind of a weird group. And he had very, very classic flexural eczema. He has no atopic background. His sister has ulcerative colitis. And then in the last couple of years, he still has this, classic flexural eczema in his antecubital folds, in his neck, he's in popliteals, but he also has this diffuse rash, which he comes in with, and is really heavily symptomatic, very itchy. He wants help. So this is a skin type 4 patient, and you can see some, again, looking more in depth, some things we may not like. He has this extensive, well-demarcated plaques on his torso. He has very clear follicular accentuation, which I can bring up here. And then he also has this kind of psoriasiform plaques on his lower back. So, a little bit uncomfortable. Is this always AD? Something changed now? So we biopsied him, and as always, it came back spongiotic psoriasiform dermatitis, so no help there. We went for, just to be on the safe side, methotrexate, phototherapy. They work for both, or maybe don't work for both, kind of similarly. And we ended up having to make a decision. So, in the context of this patient, so thinking about his skin type, we all know that follicular accentuation is a common presentation of darker skin types or skin of color, and also the psoriasiform presentation. His sister has ulcerative colitis, and this is just kind of a clinical observation. Oftentimes when we have a genetic background of psoriasis or IBD, patients tend to have these mixed morphologies. So we decided this is consistent with atopic dermatitis, and we did give him dupilumab, and he cleared up really, really nicely. I will say this is a patient I will follow up, so I'm not just going to give him a subscription via telephone yearly. This is someone we have to see. So I hope these two cases kind of show you that it's all about balancing the risk. So the clear risk, the one we all very intuitively lean towards, is we don't want to misdiagnose cutaneous T-cell lymphoma. That's really scary. But T-cell lymphoma is rare, and advanced stage T-cell lymphoma, I would say, is even rarer, while heavily symptomatic atopic dermatitis is actually common. So we always have to balance the other side of this equation, and that's we don't want to undertreat atopic dermatitis. So to summarize, I'll present our pragmatic approach to complex cases, which really meshes up nicely with what Shamir showed, so it's nice to see that. In our initial assessment, do a history, do a full physical exam. These are patients I really recommend, we have to fully undress, do the exam properly. Again, because we have to realize that we're still dealing with morphology as the basis of our diagnosis. If you have an adult onset patient, if you have one of those atypical presentations, if you have a discordance between the presentation and the skin type, this is a situation you want to go in depth, you want to do labs, flow cytometry, especially in those generalized pruritic cases or erythrodermic patients, obviously, and then biopsy. And by biopsy, I actually mean biopsies. Remember, the dermatopathologist is kind of your best friend, so it's a good, it's really important to get someone who's very comfortable diagnosing CTCL, using all the ancillary testing, immunopathology, and clonality works. And then you have to make a decision. You have to assess your suspicion level. If it's low suspicion, I would say move forward, help the patient, treat him for atopic dermatitis. If it's high suspicion, maybe take a pause and escalate your workup. In those really uncomfortable, murky patients, maybe a good time to reassess or rebiopsy. If you can consult a CTCL expert, I really highly recommend that. We're very fortunate in that we have the lymphoma clinic right next door, and we see these patients together. And when you have a dermatologist who sees hundreds of moderate to severe AD patients, along with someone who sees hundreds of CTCL patients, that's really it's a very collaborative effort, and I think it's really good for the patients. And you can go for the treatments that are fit for both, as we've discussed. Whatever you do, use that risk-benefit framing in your decision. And then finally, the treatment monitoring phase. That's maybe a phase we like to have a diagnosis and treat, but this is actually the crux of the matter here. You really have to see them, follow them up. If they improve, you probably can continue what you're doing. And if they don't, and definitely if they worsen, stop, reassess, and consider discontinuing the drug. So to summarize, we really need better diagnostic tools to differentiate atopic dermatitis from cutaneous T-cell lymphoma. And I think as clinicians, we have to acknowledge this uncertainty. We have to grow a little bit more comfortable in that space of uncertainty. And especially, I think oftentimes, I see this in younger dermatologists, we want to manifest certainty where none exists. So be comfortable saying, I'm not sure. Maximize the tools we do have, which are clinical tools, dermatopathology. We need to hone these skills. And finally, practice close follow-up and flexible decision-making. We have to stop treating the diagnosis as the end-all and just as a hypothesis that can evolve with the data we have. And definitely Osler understood this way before we did. I want to thank my close friends and collaborators from the RMC lymphoma team, great dermatopathologists. I want to thank the IEC for picking up this really important and timely topic, our patients who teach us all we know, and thank you all for staying at this time. Thank you.
Thank you so much for this wonderful presentation. Maybe Emanuela and Shamir want to come on stage for a final round of questions. Are there any questions in the audience? We actually have one question on social media. To counter pruritus and Th2 skewing in CTCL, which JAK inhibitor do you add along with standard therapy for CTCL?
Well, I try not to add JAK inhibitors at this stage because the evidence is too uncertain. To be honest, I would go more to biologic treatment in this context for itch. And then itch is, when it's a symptom of cutaneous lymphoma, it's actually a sign of disease activity. So targeting the disease with CTCL-specific treatments usually treats the itch as well, like, for example, extracorporeal photopheresis or interferon alpha or any other targeted treatment for itch. So it's not just a symptomatic treatment of a tumoral disease. We can use tools and try to help each other, but the best way to treat itch in CTCL is just to treat the disease itself, that's for sure.
I can add, I completely agree with Emanuela. I think that the itch by itself shouldn't be treated with JAK inhibitor. What I mentioned earlier is that we do treat eczematous toxicities of some of the treatment with JAK inhibitors, but that's treating, an inflammatory condition. We don't treat CTCL directly unless we do see there is an alteration of the JAK-STAT pathways through genetic analysis. But again, we are still not sure. Emanuela, you showed the data is still not clear, and actually the MF cases who were part of Dr. Moskowitz's study didn't do that well with that treatment, maybe because it was advanced stage of the disease. That's another question. But we still don't have proof that JAK inhibitors also should be part of the algorithm of treating CTCL.
Thank you. We have one question.
Thank you. Sandra Egan from Regeneron Pharmaceuticals. Full transparency. Shamir, thank you for your talk. You showed us some hypotheses on the mechanism. Why do you think dupilumab might, via the IL-13 receptor, alpha-1 receptor, might unmask, or however you want to call it, lead to the CTCL cases? With that in mind, how do you think would that transfer to the other two IL-13 inhibiting biologics, tralokinumab and lebrikizumab, where lebri only inhibits the IL-13 receptor alpha-1 receptor and tralokinumab inhibits also the alpha-2? I have my own hypotheses. I just want to ask you for yours.
Yeah, I think it takes us back to the first slides of my talk. I think there is a high expectations, but we are now, after what we experienced with dupilumab, we are more hesitant to see, because probably CTCL and the inflammation around it is much more complex than just looking at one cytokine, one pathway. Theoretically, blocking the interleukin-13 should be effective for CTCL, but we need some time to show that. At this point, what we see is that it's not making it worse. But it requires clinical trials to see if it is effective.
Yes, I totally agree that only clinical data will give us any evidence there. I think the theoretical underpinning of IL-13R2 being a scavenger receptor, but potentially being suddenly a signaling receptor, I think that derives from some neurological tumors, right? I think the evidence is relatively theoretical, and I'm not so sure that this is consistently proven to be relevant in vivo. I think it's still pretty controversial. Any other questions?
Thank you for the great stimulating session. I would like to ask Patrick, according to your experience with rituximab and MF in your clinical trial, I understand that there was no beneficial effect, but was there any bad signal, namely aggravation of the disease?
So there was no worsening of disease, no.
No, so this is very important.
Right, so we are still wrapping up the data, and we also have mechanistic studies, biopsies, and blood samples, but seemed to go neither in one or the other direction. But we hope to be able to present this data soon.
Mm-hmm. Thank you. All
right, if any other questions so far? Ah, right. What is the recommended follow-up protocol for stable MF cases or para psoriasis cases? Once a year, would that be enough? I would think so. It really depends on, you know, how the patient presents, how the history of the patient was, but I would absolutely think so, yes. And the patient can always, you know, come if there's any worsening. So I encourage patients to, you know, make an early appointment if they notice any worsening of the disease, or whether particularly they notice that they get new lesions with a different phenotype, and encourage them to come for a biopsy. But otherwise, if the patient doesn't notice any lesions that look completely different in phenotype, or that are worse, or when they don't see any worsening of the disease, I think that's totally fine to have a 1-year follow-up. I think we talked about, can I give dupilumab for itch in CTCL?
Well, one can do everything, but in the absence of positive evidence and in the accumulating evidence that it's not a good idea, I would say no.
I agree. I will avoid that.
All right. Are there any more questions from the audience? If not, then I would like to thank everyone who attended. I want to make you aware of the QR code that's going to show up where you can evaluate this session, and we would greatly appreciate all your input, because it's going to help us to plan future events. And yeah, so I want to thank everyone, and have a wonderful weekend. Thank you.